Thank you very much. As the slides are getting put up, Ashit is a very close friend, but today I completely disagree with him. Sorry, Ashit. You made a good case, but now my take is to, tell you how what you said is not right. So medial compartment OA, I'm going to make a case for a total knee replacement, friends. So if you see the X-ray which Swapnil presented, just see the lateral compartment is also beginning to get involved. And he very categorically said the patient has patellofemoral crepitus, he has anterior knee pain. So these are 2 points, friends, you have to note. So are you going to do a uni or are you going to do a TKA? Option is very clear for me. In this case, how much ever I love a uni, I would do a total knee replacement, 60-year-old lady, friends. Why? Point number 1, you see this paper, and let me just, confess that you can go through the literature and get what you want, what you like. So it's not about literature, but how you interpret the literature and what level of evidence that is. That's something which is very critical for me. So if you see this paper, KSSTA, a high impact factor journal, 1/4 of the UKs were revised for lateral compartment progression, and out of the 114, 50% showed progression of at least grade 1 in the Kellgren-Lawrence grade. So that is something you got to note, friends, that the lateral progression is seen. Now, if you see the contraindications with my friend Ashit himself showed, lateral compartment, lateral facet patellofemoral arthritis. And here also you see there is some beginning of lateral facet arthropathy. So again, not a good case, definitely not. If you see the registries all over, the Australian registry, the New Zealand registry, data is not conducive. The New Zealand registry shows a 3-time higher revision for UKs than TKA. The complication rates in all these registries, you can see them have reported a higher complication rate. So I think this is one more valid registry data. This is not even a paper. This is actual factual information. Next point, the learning curve of UK. Now, again, if you just do 1 uni a month, that's not enough. That's going to give you higher complication rate. So you should be at least doing 2 unis, about 24, 25 a year. And that's where, we call a high volume surgeon. Otherwise, you have a higher risk of dislocation, instability, malalignment, and, these are all the complications which you're seeing. And again, the flip side too is that if you're even doing too much, that more than 25% of your unis are of your TKRs, knee arthritis are unis, then you even have a higher complication rate because you see a uni in everything. So that's something which you have got to be careful for. And as mentioned, the criteria for selecting a uni are very, very stringent. And how often do you meet this? In our country, the patients come quite late. And if you tell them that, okay, I'm going to try this operation and there is 20-30% chance that you may progress and you are going to get a TKR, half of my patients chicken out and then they rather go for a total knee replacement. It's again the way you talk to them, how you convince them. That's very important. If you tell them that uni is like, the God's gift to arthroplasty, then they will be convinced for that. But if you tell them facts, you talk to them, these stringent criteria are not met with, which most of the time the patients I see, they are not met with, then definitely, a TKR is a better option than uni. Because these are the criteria given by the Oxford group. So why in this particular case I want to do a uni? I want to do a TKR, friends. I completely disagree with Ashit here in this particular case. UK is technically challenging. Your tibial cut is the most critical cut. If your tibial cut goes wrong, then everything goes wrong and you can get a higher chance of fracture. How much do you cut? When you're taking the oscillating saw cut, you may damage the ACL, you may damage the PCL behind. That's what I have seen. So that's a very, very technically challenging operation for me. And for me, a knee replacement, I can close my eyes and do a knee replacement. But when I do a uni, it's not that I don't do it, let me be honest. I take twice the more time than a TKR, and I am always in attention and a little bit stressed when I do a uni. Results of UK are less reproducible. I've seen that. Whenever I do a uni, I cannot be 100% sure that my patient is going to get a pain relief. Sometimes they are not. While in a TKA, I can almost, confidently predict that this patient is going to get pain relief and I am more at ease. Whenever uni patient, I meet them somewhere in social functions and see them, I run away from them because I'm not sure what they are going to say to me, whether they are happy or not. Point number 3, pain relief is completely not assured. Some of the unis, now let me give one point to Ashit here. If they are happy, they are extremely happy. If they are unhappy, God save you. They are, come to you and, all those complications which he himself showed in the articles, bearing dislocations and all that, because it is very technique dependent. High chances of progression. I have already elaborated on that point. Lateral progression can be seen, patellofemoral arthritis can be seen, and then, you've got to revise it. Now, the final nail in the coffin, revision of a UK, let me tell you, and I have done about 8 or 9, they are quite difficult than revising a primary, because you just get medial bone loss, deep medial bone loss, the lateral side is intact, you have to cut the lateral side to match it to the medial side, and these revisions can be quite complex. Revising a uni, again, for me, in my hands, average surgeon like mine, is quite difficult. Rather than, doing a regular replacement, you do a TC3, LCCK or a hinge, it's not a problem, you get those bone defects covered. But converting a uni to a TKR, those of you who have done it, it's difficult. And last but not the least, again, I am a very average surgeon. In my hands, TKR works, and TKR is something which will give an assured result to my patient. So that is why in this case, friends, I will not hesitate to do a knee replacement. I started with a bang in doing uni. Forget what all I said now, but let me confess, my number of unis have gone down significantly in the last couple of years than what I did 4 or 5 years back. So with this, friends, no hesitation for me in this case to do a uni. And let me ask Swapnil, what did you do? No hesitation to do a TKR in this case. I will do a TKR, definitely not a uni. And Swapnil, what did you do? So let us see what he did, and that would probably be the final jury. Thank you very much.